can see where it's impacted and embedded against the wax. They are quick to deny it, which is understandable because they don't want me to know. So I immediately, because of the consistency of this wax, it's very dry and sticky. And I did try to perform a bit of microsuction, just put some olive oil drops in straight away as well, just to soften it. And this is right near the entrance. This, as you can see, it's almost camouflaged by the hairs. Well, this part of the wax plug. So I'm just using an ear hook initially just to detach it from the base of the ear canal. And now I'm using some forceps, and you'll see I'm going to extract a rather large piece of earwax here, but there's still a larger one left in the ear. If you watch till the end, you'll see some still images, some close-ups of the wax plugs. So there's plug number 1, and that's got a bit of keratin around the edge. So that keratin, that skin, was enveloped around the wax, but it was also attached to the ear canal, and that's why there was a bit of resistance there. So this is the medial plug. This is the bit where it was very obvious that the patient had pushed this and lodged and wedged and clogged this up against their eardrum, and it was quite a severe impaction. Once I remove this plug, you will see that the ear canal actually narrows where we are now. You can sort of see the ear canal wall on the right, and it's a natural narrowing in the ear canal called the isthmus. It's about 0.5 centimetre away from the eardrum. Then the ear canal widens again. So this plug of wax has been pushed through the narrowing into the wider part, into the recesses. We have an anterior recess and an inferior recess. So a recess like a trench or open cavity. And with this isthmus, it creates an inferior recess, kind of like a basin at the bottom, like a trench at the bottom of the eardrum and ear canal, and one to the right. In the case of the right ear, we call that the anterior recess. So just put some more drops in there. I'm just trying to mobilise this out of the narrowing, and just on the posterior canal wall, just a flake of dry skin and wax. Just remove that. You can see I'm trying to insert the endoscope around the hairs, because the hairs sometimes, because we put a lot of drops in, they can cause a bit of blurriness. The bones here at the moment, however, it's not due to the hairs, it's just the oil that we're suctioning. It can cause almost like a prism effect. You're looking through some glass at an angle. And again, just curling around the hairs. So I think I'm going to go to the top part now, superiorly, because it is really, really large, and I want to just detach it from the roof of the ear canal. With this type of wax, it's almost solidified as well, so I suspect originally it's a bit softer. It's got this clay kind of consistency, and it's solidified and attached itself. The skin adhesions have become quite strong here. So I'm just trying to peel this down and away from the top of the ear canal. You can see it's coming off the back part, the posterior canal wall. A segment of this wax are detached from the suction probe, so just remove that. So I'm just going back in, and we're using a standard Zollner suction probe here. So the ear canal is a bit narrow. You can see there's limited space for the Zollner suction probe to work itself in the ear. So it can't be as rigorous as normal, where I can really wiggle and jiggle that suction probe, because there's not much space for me to do that inside this patient's ear. So I'm just going back to the bottom of the ear canal, where it's really lodged. I sometimes find when you've got a larger wax like this, it's normally lodged inferiorly in the inferior recess. If you get the wax plug and suction it up and away, so moving the suction probe from south to north, from 6 o'clock to 12 o'clock, that can immobilise the plug of wax, which I think I more or less have done now. I've taken it, I've lifted it, should I say, out of the inferior recess. And when I got a suction grip here, just got to be careful. I don't want to withdraw the suction probe too quickly, because then I lose the suction grip. So you need a bit of touch there. You need to be able to feel this wax, and you kind of know when you're going to lose suction grip. So you just go back, you try and redraw the suction probe accordingly and not too quick. So this is another huge piece of wax. So just going into the ear, and you'll get an appreciation of the narrowing of the ear canal. You can see the narrowing to the right, and it widens again. So that's the patient's right ear. So they are a YouTube fan, so I suspect they'll be watching this. We did airdrop the video to the patient as well after the procedure. So this is the patient's left ear. I've immediately just put loads of drops in because it's the same problem. The left one wasn't as bad though, but nonetheless it was still clogged. I've really dosed the ear with olive oil just to really lubricate the plug of wax, because it is quite dry, as I said. It's a bit matted. It's almost like it's almost like a stone-like consistency. It's really rough. So I'm just again going to go to the top of the ear canal here, and I'm just going to peel it down off the canal, the roof of the ear canal wall. There's quite a few strong skin adhesions here. You can see we're near the entrance. You can see the cilia, the hairs there. Now that I've detached it, I'm going to get a suction grip and I'm going to gently wriggle this slowly out of the ear. Again, I don't want to withdraw the suction probe too much, or too quickly should I say, because then I'll detach it from the wax plug. See a long slither of wax there. So it's going to go through the patient's hairs, and there's a lovely view of the eardrum. And again, the patient has got a narrowing, the isthmus towards about 0.5 centimetre away from the eardrum. So it's just some sticky wax on the lateral posterior canal wall. So lateral means near the entrance, medial is the opposite, so that's towards the eardrum, so further away. And this is the posterior canal wall, the back part of the ear canal. There's often a blind spot in here, posteriorly and laterally. And if you can get the wax out of the blind spot, it facilitates the easier removal for the rest. So there's some close